Our next esteemed faculty is Dr. Ashok Kirpalani, who is a Dean of Nephrology. He is a former professor and head department of nephrology, Grant Medical College, JJ Hospital, Mumbai. He's former president of Indian Society of Nephrology, Indian Society of Organ Transplantation, Hypertension Society of Hypertension. He has performed more than 2,000 kidney transplants. He's a university teacher since 1977. He runs 2 specialty hypertension clinics in Mumbai and has multiple publications and chapters in medical nephrology textbooks. And he's a masterly approach, and his deliberations leave an everlasting imprint on the minds of the audience. So I hand over the mic to Dr. Sanjay Gupta to conduct this session. Dr. Sanjay Gupta, please.
Thank you, Professor Manoria, for giving me an opportunity to open this topic. This is a very usual looking topic, but the crux of the topic is very unusual because we know the angiotensin 2 is the molecule of the century, which is associated with CV morbidity and mortality. And this is well established that inhibition-based interventions and pharmacotherapy has always been successful in reducing the CV hard endpoints. And there is ample evidence of its anti-proteinuric effect and beneficial effects in early CKD, especially the diabetic CKD. But there is lack of hard evidence in advanced CKD and in patients who have GFR below 30 ml. Because most of the larger trials and larger studies have excluded patients who had GFR below 30 ml. So there has always been a quandary, there has always been anxiety in the general physicians and in the treating nephrologists also for the faster progression of CKD to dialysis. Then there are chances of developing hyperkalemia and aggravating metabolic acidosis and so on. This topic is now being handed over to none other than Professor Ashok Kirpalani, who has been a doyen in the field of hypertension as far as India and the world is concerned. So I request Dr. Kirpalani to start his deliberations on this topic of RAS inhibitors. Thank you.
Good afternoon, and it's a pleasure to be with Dr. Manoria's annual meeting every year. He has been kind enough to invite me to speak on the recent advances in renal disease. And today I will be speaking to you about recent advances in CKD care with particular reference to those new drugs that have enhanced the care of the patient by acting on the renin-angiotensin-aldosterone system inhibition. We know today that the CKD is classified not only according to GFR as it was in the past, which is the table you see on the left side, and there are actually 6 stages, G1, G2, 3A, 3B, G4 and G5, but also according to albuminuria, because albuminuria or proteinuria are equally important. And therefore, today we know that if you look at the picture, the A1 is normal to mild proteinuria, A2 is moderate, and A3 is severe. And if there is a drug or a group of drugs that can shift the patient from A3, G2, as you see in this arrow pointing to you, shown to you, and bring the patient down to an A1 proteinuria, even if it means reducing his GFR, you are not doing him harm, you are doing him good, because the colors are green, pale yellow, orange, and red. And this is the degree of seriousness of the illness. So today we are looking at ways of bringing down not only the rate of decline of GFR, but also the proteinuria in our CKD patients. Now, the clearly established approach to retarding the progression of CKD is as follows. First of all, is specific measures. Treat the causative illness. If there is a glomerulonephritis, then treat that with whatever immunosuppressives, lupus therapy, etc. If there is a blood glucose elevation in diabetics, bring the blood glucose down to reasonable levels, control the blood pressure, and immunosuppressive therapy in medical diseases, immune-mediated medical diseases. Now, over and above that, when we cannot prevent more immune disease, you've done your best and you brought it under reasonable control. In spite of that, diseases like diabetes, hypertensive nephrosclerosis will continue to deteriorate in spite of good control of blood glucose, blood pressure. And there are non-specific measures. And the foremost are reduced proteinuria. Be careful that you don't kill the patient with hyperkalemia. Reduce the blood pressure and reduce the effect of the main cytokine, that is the angiotensin 2 and the whole angiotensin 2 cascade, which now includes renin, angiotensin 1, angiotensin 2, the receptors, and thereafter the aldosterone. So when I say RAASI, inhibition of the renin, angiotensin, aldosterone system is a total way of retarding the progression of renal disease in a non-specific way in all renal CKD, which is otherwise now then deemed incurable. Over and above there, we will have dietary interventions, anemia correction, acidosis correction, metabolic bone disease correction, uric acid reduction, and avoidance of nephrotoxic drugs. But that's not my agenda today. Now, the first thing that we today believe is that in nephrology, heart is king. What does that mean? It means that even as you see in this pyramid or this, shall we say, iceberg, the end-stage renal failure is right at the top. The lowest is the patients at increased risk of disease. There are probably in every country 10 to 15% of adult population is suffering from CKD. But what we recognize today is there's a huge number at the base at increased risk of progression, but a very small number at the top. And the reason is that even as kidney failure progresses and goes on to end stage, on the other side, there is cardiovascular disease and cardiovascular events, coronary artery disease, left ventricular hypertrophy, strokes, etc., together with various other factors, which go pari passu and put the patient at risk of dying prematurely before reaching renal failure. So that almost out of 1,000 patients of CKD, only one will ultimately die of kidney failure, that is on dialysis, on transplant. All the rest, either they remain static or they die from other diseases, and the other diseases are mostly heart failure. Now, we know by all means today that the renin-angiotensin system blockade is the most important feature, which has a 1A recommendation in all the guidelines. And how does that work? It first of all reduces the blood pressure by vasodilatation, and I need not tell you how angiotensin is blocked by these ACE inhibitors, ARBs, and also by the aldosterone inhibitors. They reduce proteinuria, they increase natriuresis, they reduce the expression of cytokines and growth factors, they reduce the macrophage infiltration and reduce myofibroblast proliferation, not only in the kidneys, but also in the heart. And all these lead to renal protection and heart protection. Now, what are the limitations of this RAS blockade? It is a, first of all, serious problem that most patients will experience 5 to 10% of rise in serum creatinine. This may be due to various factors, and most dangerous if it is due to volume depletion, because it can precipitate. The other most dangerous thing that happens with this, which has to be watched out for, is hyperkalemia. And these are the two limitations, the primary limitations to the use of these drugs. Now, the safeguards while initiating these RAS inhibitors is one that we do not use them in bilateral artery stenosis. We watch the GFR and potassium after starting these drugs, and every increase in dose is very important to be noted, especially in the first few days, and anything more than 25 to 30% needs withdrawal of these drugs, and situations needing review of prescription as shown in a patient, you have to withdraw these drugs preemptively in CKD if you are putting them through open heart surgery, if they have gastroenteritis, any hypovolemic, hemorrhagic, acute shock stage, and concomitant use of nephrotoxic drugs. So let me come to the one very first useful new innovation, and that is that we know today that a large number of our patients not only have CKD, but they have heart failure. They have, of course, HFpEF, which is half heart failure with preserved ejection fraction, which is a fair number. But a fair number is also heart failure with reduced ejection fraction, which makes the life of a mild CKD patient miserable. So let us see, this lady has comes with a clinical history and investigation, reveals a creatinine of 2.4, ejection fraction of 2.28%, EGFR of 34, and a blood pressure of 120/80. The patient needs to be initiated on optimal heart therapy for better clinical benefits. Now, you physicians sitting in the audience know much more about this drug than I do, because it has been in use, and it is a prolifically used drug by the Novartis company, which has got a monopoly on it, and now I believe 2-3 other drug companies have come in. And such a patient would first, in the past, have gone to ACE inhibitor or ARB therapy. But with this new drug called ARNI, which is the combination of sacubitril together with the ARB valsartan, this drug has made a life very much simpler for the patient who has no CKD. And a large number of your patients are walking around with a very comfortable heart because of this drug. But in CKD, there has been an anxiety about using this drug. What is the additional sacubitril which inhibits neprilysin? Neprilysin is a neutral endopeptidase. It's the key enzyme responsible for the degradation of natriuretic peptides. It is membrane-bound metalloproteinase, maximum located in the brush border of the proximal renal tubules, and on other sites also, brain, vascular, wherever there is a natriuretic peptide, there is also neprilysin. And neprilysin catabolizes natriuretic peptides and also catabolizes the vasoactive peptides like bradykinin, substance P, and unfortunately also it destroys destroys angiotensin II and endothelin. So anything that inhibits neprilysin will inhibit the destruction of natriuretic peptide, but also of angiotensin II. And this is the reason why two drugs are combined, so that if there is too much angiotensin II, it is blocked by the valsartan. And here is data which shows that in CKD patients, now I'm stating again, in CKD patients, when compared with an enalapril, there is a 21% reduction in cardiovascular death and heart failure hospitalization when ARNI is used. And the rate of decline of EGFR between the two drugs shows the superiority of sacubitril valsartan as the ARNI in compared to enalapril. That means the enalapril will decline faster than the sacubitril valsartan group. And therefore, using this drug, I strongly recommend, particularly in our patients. One is that most of these patients who have HFrEF already have a low blood pressure. And lowering their blood pressure further, you will see patients walking around with 100/60 blood pressures. So we have to watch the blood pressure, you have to watch the EGFR, and watch the potassium. And in our case, in CKD patients, we prefer to hospitalize the patients for the first few days and frequent revision of prescription according to changes in the above titrated responses. So you have to be careful that you don't drop the pressure too low and cause these two problems. Now, coming to a novel new drug called Finerenone. is a novel non-steroidal selective MRA that has a high affinity for the mineralocorticoid receptor and a unique binding mode to block mineralocorticoid, that is activity of aldosterone, and reduce inflammation and fibrosis in CKD and T2 diabetes. Now, we know that in CKD progression is driven by the combined effects of metabolic, hemodynamic, and inflammatory and fibrotic factors. So the patient not only deteriorates in diabetic T2 diabetes because of just the blood glucose, but the hemodynamic effects of elevated blood pressure and intraglomerular pressure, which are through the renin-angiotensin system causing damage, the metabolic factors due to poor control, and the various metabolic factors shown in this slide, and most important, the inflammation and fibrosis, which is really what we are looking at. And they all together produce tubulointestinal damage, inflammation, glomerulosclerosis, mesangial expansion, and glomerular hypertrophy. Now, this Finerenone has a direct mechanism of reducing and targeting the inflammation and fibrosis that is seen in T2 diabetes. So here is what you see on the slide, that the hemodynamics are taken care of by the ACE inhibitors and the ARBs. The SGLT2 inhibitors and the various new anti-diabetic drugs take care of the metabolic factors. But for the inflammation, the Finerenone is unique in that it is anti-inflammatory, it's anti-fibrotic, the effects are in preclinically model proven. It reduces albuminuria independent of measured changes in blood pressure. Even with the same blood pressure, the degree of albuminuria reduction is very good. Next slide. Now, the mechanism of this is that you see here the role of angiotensin 1 and 2 in the renin-angiotensin system, and the site of actions of ACE inhibitors and ARBs marked sharply in red. Now, when you block the angiotensin 1 and 2 at these sites, you automatically also reduce the release of aldosterone, which would have otherwise increased blood pressure and increased blood volume. So long-term renin-angiotensin system blockade with ACE inhibitors and ARBs results in incomplete suppression sometime, and that is called aldosterone escape. So we know that in short duration, the aldosterone is blocked properly. But over a period of time, and in patients with diabetes, hypertension, heart failure, and prolonged usage and severe proteinuria, those are the patients, I repeat, severe T2DM, severe proteinuria, and heart failure. These are the patients who go through aldosterone escape. And these are the four mechanisms by which the aldosterone escape occurs. There is the most important is that the increased ligand-dependent mineralocorticoid activation by aldosterone. This is one mechanism because of the ligand itself. And there's also, because of the steroid-like effect, cortisol-like effect also occurs on the ligand and causes aldosterone escape. The most important is that increased ligand independent also, there is nothing to do with the ligand, but when there is extra activity of the RAC1 due to CKD, heart failure, and T2D, and the increased MR expression over a period of time. It doesn't happen immediately, but the expression of the MR receptors is increased when there is severe proteinuria. So albuminuria of more than 2 grams would have caused aldosterone escape. Now, because of this aldosterone escape, there is uncontrolled fibrosis at the level of the interstitium of the kidneys. And this Finerenone is a drug that blocks it. Now, what is it that makes it different from spironolactone, eplerenone, and why is it better and more useful? Now, just to show you how the three MRAs, mineralocorticoid receptor antagonists, differ from each other. The first two are steroidal, and they are small and flat, whereas the Finerenone is a larger molecule. The aldosterone, original aldosterone inhibitor, spironolactone, has a very powerful antihypertensive effect and is best suggested for usage in resistant hypertension. As against that, eplerenone is also used mainly for hypertension, and because of its unique lesser action on the incidence of gynecomastia and feminization in men, it has a good effect. Of course, it has a shorter half-life. On the other hand, Finerenone is a larger molecule. It has a very strong potency for all mineralocorticoid receptors all over the body, including the heart. It has a short action and it is very useful, particularly for the purpose of preventing fibrosis and interstitial disease in the kidneys and in the heart. Now, the last part of my talk is on hyperkalemia. You see, all the renin-angiotensin blockade is fraught with the danger of hyperkalemia. It limits the usage of these life-saving therapies, including Finerenone, which can also cause hyperkalemia, but to a lesser extent. Now, the drug that we use ordinarily now in India is calcium resonium. It has a very good effect on exchanging calcium for potassium and leaching out potassium and getting rid of it in the stool. But there are many adverse effects if you use it more than 3, 4, or 5 days in a row. And you can see the gastrointestinal effects, and it occasionally can cause hypercalcemia and hypokalemia. But mainly, you cannot use it for a long period of time. So short hyperkalemia, yes, but long-term usage over months and years concomitantly with the ACE inhibitors, the ARBs, the valsartan, and the Finerenone will need a better drug. And next slide. Patiromer is a new binding agent that binds potassium and exchanges for calcium. It is a calcium salt which has a ratio of 2:1 with sorbitol, and it forms a combination called the patiromer-sorbitex calcium combination. And this drug can be used over many, many months together with renin-angiotensin blockade, where it is very useful and does not cause hyperkalemia. And the mechanism is of action and how to use it is that it is an oral drug, 8.4 grams twice a day. It's called Veltassa, and abroad it is available. Soon you will see it in India, and is dissolved in water and used just like the potassium binder called calcium resonium, which we have been using for many years. It really releases calcium for potassium and increases fecal excretion of potassium, reduces potassium level, but very important, it cannot be used for acute hyperkalemia because it takes about 7 hours to work. Therefore, it has to be used only in chronic situations over a long period of time. And the effect lasts even for 24 to 48 hours after stopping. The side effect profile is much more favorable for chronic use on long-term basis as compared to calcium resonium. There is one more drug called zirconium cyclosilicate. Now, patiromer removes potassium and replaces it by calcium. However, zirconium cyclosilicate removes potassium and replaces it by sodium, which unfortunately can worsen hypertension, fluid retention, and heart failure. And it is very similar, and the limitation is also very similar to the drug called sodium resonium, which is now no longer used because of this effect. But it's also been used and may soon reach India, and this can also be used for a long time. So if there is no real danger of patients having sodium overload, then this drug can also be safely used. With this, ladies and gentlemen, I have tried to explain to you what is new in the armamentarium of renin-angiotensin system blockade today and what you can expect for your patients to use this blockade more favorably and better care of the patients and avoid the side effects that come from it. Thank you.
Thank you, Professor Kirpalani, with your lucid disposition about the use of newer agents and use of RAS inhibition, SGLT2 inhibition, and use of Finerenone, that is MRA, in CKD patients. Now the session is open for discussion, questions, and comments.
Dr. Kirpalani, I have some basic questions.
Yes, sir.
Is it that Finerenone is reserved for use only in interstitial disease of the kidney, or can it be used in glomerular disease also? First question.
Sir, the point is that it is very similar to spironolactone. And it's very useful, specifically at the moment, proven for interstitial disease progression in diabetes. It has not been cleared non-diabetic, although I believe that sooner or later it will get cleared for non-diabetic also. But in diabetes, particularly those with very heavy proteinuria and concomitant heart failure, it is very useful. And so it has been started used in the USA. More trials are on. Of course, you must forgive me for not including gliflozins and SGLT2 because they don't work through the renin-angiotensin mechanism. And I felt that I should go in depth with something new. Every physician in this audience must have been bombarded with the DAPA CKD trial and already know that gliflozins are very good for heart failure, non-diabetic heart failure, and non-diabetic CKD also. So I see a role specifically targeted to the interstitial nephritis, and glomerular disease is better taken care of by the renin-angiotensin system. So these drugs will be used together. They will not be used instead of. And they will try to minimize the limit the amount of potassium difficulty. That's why it is. But I think that sooner or later there will be a trial with DAPA and this, because the effect of DAPA is probably stronger, or all the SGLT2, not only DAPA. It just so happens that DAPA had effect, was the first one to be proven by trial, but others are also soon coming out, the EMPA, etc. And they will all be, it's a class effect, and they will have additive effect. And specifically because of the potassium problem and the severe hypotension that spironolactone causes and eplenorone also causes, this drug is specific for diabetic interstitial fibrosis and not so much for glomerular disease.
So does it affect the intraglomerular hemodynamics like the RAS and the SGLT2?
No, it is more specific for the interstitial nephritis. Now, doesn't have that much effect on GFR.
5 to 7% patients in these Finerenone, both the trials, all three drugs were used. I could not get access to data. So do you have any comments on when all the three drugs have been used in that 5% patient?
To be honest with you, there's not much data. I mean, the pressing emergency is diabetes. And most of the data is in combination with ACE inhibitor ARBs. There is data. Most of the trials have ACE inhibitor or ARB together with Finerenone. It is not separate. And they have shown an additive effect. But they haven't shown anything with DAPA. And I think that DAPA or any of the SGLT2 will probably be more combined effect with RAS. And this will come as an add-on for interstitial nephritis, particularly in those who are in late phase of the disease.
The other issue which we face is we have patients of CKD who are in very bad heart failure.
Yes.
Their eGFR is less, say 15, 17, 18. So when we administer SGLT2 inhibitors, their heart failure improves, but we are at a risk of progression of CKD. So what is the risk of progression of CKD with SGLT2 when given this subset, because it doesn't affect potassium too much?
Yes, that's a very good thing, yes.
Should we use these agents as an off-label for this subset where heart failure is distressing, CKD is, say, stage 4, 15 or 17 or?
Yes, with very poor ejection fraction, there is clear evidence that whether that is diabetic or not, the DAPA should work very well. The SGLT2 should work very well. There is no doubt about that. That would still be the better drug as compared even to eplerenone. I'm sorry, as compared to Finerenone. But the difficulty is that there is a large amount of exclusion with SGLT2, because anyone with prostate outlet disease, old ladies with senile vaginitis and recurrent UTI, they are prone to very severe infections. And therefore, this drug, and you can't use it in type 1 diabetes anyway. So this drug will fill up a gap, which is, all these drugs have gaps. I showed the gaps of the ACE inhibitors. I didn't talk about SGLT2 has many gaps. And therefore, this drug will come as the third in the armamentarium to fill up the gaps in the care of CKD progression.
The other issue is RAS blockers, of course, are used first and then SGLT2 because they came first. A new thinking is emerging because when we initiate SGLT2, potassium is not much affected compared to RAS blockers where there's always a threat. Blood pressure is not much affected by SGLT2. RAS blockers definitely or ARB definitely affects blood pressure. So is it that a trial may be conducted to see whether SGLT2 initiated first followed by RAS? The reverse orders would be better. What is your viewpoint on this speculation?
So far, see, the recommendation for the recommendation is always 1A for RAS. So yes, not treating with RAS is probably not acceptable. And therefore, only if discontinuation or addition it is accepted. I don't think that in a non-diabetic, in a diabetic, yes, SGLT2 first, metformin, then SGLT2. But in a non-diabetic, the recommendation is still RAS first, RAS inhibition first, and then SGLT2. And then perhaps Finerenone as an addition, particularly in the late stages of the disease. By the way, just for your information, fair number of my patients already are receiving Patiromer. And we approached the DGCI or whoever is the drug controller of India, and they freely give a permit to import. It's a little long procedure, but I have about 8-9 patients who are receiving.
Cost, quantity cost?
Oh, it works out to almost 15,000-20,000 rupees a month. Per month. Month. Yeah, very expensive, but it will come down. I mean, there is no question. What comes to the rich will filter down to the poor in due course, because you've already seen that even the Novartis Vimada is now in 3 other companies, and the Linagliptin, which is the nephrologist's favorite, is now in 25 companies, and Japa is in 16 companies. So it will filter down once it reaches, yes.
Professor Manoria, you put out a question about the proteinuric diseases and interstitial diseases. What I understand is that all proteinuric diseases finally end up with the interstitial inflammation and fibrosis. And that is the point where the MRAs, they act. MRAs are antifibrotic agents. So probably in progression, in checking the fibrosis and progression of CKD, the Finerenone has a role there. As far as SGLT2 inhibitors are concerned, I feel that with the recent advances, the DAPA CKD took the patients who had GFR less than 30 ml per minute, and probably the EMPA kidney, which is in the pipeline, would take patients who are having less than 20 ml of GFR. Probably progression of kidney disease issue would be more addressed. And I think without heart failure and without diabetes also, the CKD patients may have a guideline to use these drugs in future. Sir.
Yeah, absolutely. I agree, because the limitation is that as the GFR falls, the number of nephrons die. And so the tubules are ineffective. They start to, so the blunting of the effect of SGLT2 comes in, because the number of tubules is less, so where will it work? It has to work on healthy tubules. That's the problem. Otherwise, it has less limitations, no doubt about it.
But sir, the conundrum about the ACE inhibitors and ARBs, which is amongst the general population, and most of the nephrologists are also, they come into picture and are being asked about this question, that when to stop the ACE inhibitors. This is the biggest question, especially in a patient who is a diabetic, especially in a patient who is having heart failure also. You are using ARBs or ACE inhibitors, and when to stop. If you stop, the CVD mortality increases. If you continue, the patient goes towards end-stage renal disease and renal replacement therapy. That is the biggest dilemma before the clinicians at this stage.
You are absolutely right. And that's why I believe that when patiromer comes, there is no end point. The end point is only that. Of course, GFR fall of more than 20 should be immediate stoppage. One should not withdraw permanently. One could revisit and come back, because withdrawing causes a more rapid decline than there was before. This is well established now that if you withdraw and don't re-enter quickly, the rate of decline of GFR further gets rapid, and the patient actually then rushes into CKD. So the important thing is frequent visits to the doctor, frequent adjustments of the prescription, watching the BP and the potassium, and then coming back to a lower dose. And if you are lucky enough to somebody who can afford 20,000 a month, then you buy the patiromer and use it.
As you mentioned about the escape phenomenon in RAS inhibitors, if we remember in 2010, 2011, there was a study called On Target by Salim Yusuf at McMaster, Canada.
Yes.
And this study was very particular in saying so that if you use two RAS inhibitors together, the number of those advanced CKDs reaching the end-stage renal failure was high. So they dissuaded using the two RAS inhibitors together. An ACE inhibitor and an ARB should together not be used in advanced CKDs. What do you say about it?
Precisely because both ACE and ARBs work on glomerulus, whereas the MRA works on, as you said, on the tubules, maximum, and on the heart. The most important thing also works on the heart. That's where the beauty of it is. So you are limited, otherwise you can work.
Right.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.